proteinuria. So it is the diagnosis is the nephrotic syndrome, massive proteinuria is there, and marked edema of body is there. So this is case of nephrotic syndrome, and write down the causes of the nephrotic syndrome in the children. Mostly the minimal change disease or the focal segmental glomerular nephritis. Then next is the 35-year-old male presents with the easy fecundability and yellowish discoloration of eyes. Means patient has jaundice and typical faces, anemia, jaundice, and splenomegaly. So these features are anemia, jaundice, and splenomegaly are the features of hemolytic anemia. So patient has HB 4 gram per deciliter, raised unconjugated bilirubin, reticulocytosis increased in the hemolytic jaundice, raised LDH, again LDH increases in the hemolytic jaundice, and peripheral blood smear show cystocytes. So what is your diagnosis? Diagnosis cystocytes in peripheral blood smear and 35-year-old male. So there may be the feature of hemolytic anemia, most probably microangiopathic hemolytic anemia. So what are the points in favor? Hemolytic anemia, points in favor of hemolytic anemia is decreased this HB, raised unconjugated bilirubin level, raised LDH, and reticulocytosis. And the features of microangiopathic hemolytic anemia is presence of cystocytes in the peripheral blood smear. So these are the points in favor of microangiopathic hemolytic anemia. Next is 27-year-old male with a history of intravenous drug abuser. So he comes to the emergency department with complaints of anorexia, fever, and jaundice. The serum aminotransferase levels are raised. Liver biopsy show ground glass hepatocytes with central ballooning degeneration, and viral HBs antigen is detected in the serum. So what is your diagnosis? Your diagnosis is the viral hepatitis. And what are the complications of viral hepatitis? This may transform into the chronic hepatitis. Patient may have cirrhosis, and patient may have hepatocellular carcinoma later on in the life. So this is the case of viral hepatitis, and complications of viral hepatitis, chronic hepatitis, cirrhosis liver, and there may be the hepatocellular carcinoma. Next is the 30-year-old female living in Delhi has worsening nausea and malaise for 1 week. So patient has the 1 week history. On examination, patient has jaundice, liver size is increased, and tender hepatomegaly is there, and she is 16 weeks. She is at 16 weeks gestation. So 16 weeks pregnancy is there, and serum these liver enzymes, the AST and ALT, they are increased. And what this and patient has the history of taking the contaminated water. And what is your diagnosis and what is the prognosis? So since this is a case pregnant lady having features of jaundice, and so it is because of the viral hepatitis, probably it is because of the hepatitis E infection. So in pregnancy, these females are prone to infection with hepatitis E, and when the pregnant female is infected with hepatitis E virus, this prognosis is very poor in these cases. So hepatitis E viral infection and prognosis in pregnant ladies is very poor. Next case is 35-year-old woman works at tattoo artist, has an increasing malaise, nausea for 2 weeks. On examination, patient has jaundice, tender hepatomegaly. These serum AST and ALT are increased, bilirubin is increased, direct bilirubin is increased, and patient has continues to have a malaise for next 1 year. So patient has past history of similar episodes for 1 year. Liver biopsy shows the minimal hepatocyte necrosis, mild steatosis, and minimal portal bridging necrosis. So this is again the case of hepatitis, viral hepatitis, hepatitis B infection, and complication again chronic hepatitis or cirrhosis and hepatocellular carcinoma. So then 4-year-old male child is brought by the mother in the pediatric OPD with low-grade fever, headache, and bleeding from nose. On examination, so we will do the blood count. Patient has anemia, leukocytosis, and platelet are reduced, thrombocytopenia. Anemia, thrombocytopenia, and leukocytosis. Diagnosis, child of 4 years, so diagnosis is acute leukemia, possibly acute lymphoblastic leukemia. You will do the bone marrow aspiration and do the flow cytometry and cytogenetics. Next is patient is 70-year-old male, complain of pain, lower back, fatigue, increased pallor for 1 month, And on examination, patient has tenderness over the lower vertebral region. On X-ray, there are multiple lytic lesions in the pelvis and the sacrum. So this is the typical history: old aged patient, lower back ache, fatigability, anemia, and the lytic lesion in pelvis and sacrum. This is a typical case of multiple myeloma. So how will you confirm the diagnosis? How will you investigate? You will do the bone marrow and see the plasma cells in the bone marrow aspiration and biopsy. And then there is CRAB criteria. CRAB criteria. Patient has CRAB is hypercalcemia, R means renal involvement or renal failure, A means anemia, and B means bone. There are lytic lesions in the bone. And you will confirm the diagnosis by the protein electrophoresis or immunoglobulin electrophoresis, where we see the M band. So M band is seen in the immunoglobulin electrophoresis. So this is required for the confirmation of multiple myeloma or plasma cell dyscrasia. So this is case of multiple myeloma. You will do the bone marrow aspiration and biopsy to see the plasma cells in the bone marrow aspiration and biopsy, and you will do the this immunoglobulin electrophoresis, where you will see the protein electrophoresis, where you will see the M band in the electrophoresis. Next case is the 45-year-old male with a history of acute onset of severe headache, high-grade fever, generalized weakness, drowsiness, photophobia, neck stiffness, and flu-like symptoms and diarrhea. So patient, we did the CSF examination, and TLC was raised, and DLC was done, and there was the lymphocytes are more in number than the polymorphs. Proteins and glucose levels are normal. So this is typical case of viral meningitis. Why viral meningitis? Because lymphocytes are increased and glucose and protein are almost normal. So this is viral meningitis, and points in favor: TLC is increased, lymphocytes are there in the DLC, and protein and glucose levels are normal. So next is 55-year-old male with weight loss, weakening, prolonged history of abdominal discomfort. Patient reveals the massive abdominal discomfort, maybe because of the splenomegaly, and the examination, massive splenomegaly is there. On examination, patient has anemia, mild anemia. There is leukocytosis, 280,000 per microliter of WBCs are there, and patient has normal platelet count. So old age patient, massive splenomegaly and leukocytosis and mild anemia, and platelets are normal. Probable diagnosis: myeloproliferative chronic myelogenous leukemia, CML. So this is the case of CML. And how will you investigate the case? You will do the cytogenetics to see the Philadelphia chromosome and translocation 922. So 922 and translocation and Philadelphia chromosome is seen in the CML, chronic myelogenous leukemia. Next case is 20 days old neonate having chief complaint of fever, irritability, seizures for 7 days, vomiting 4 days, refusal of feed is 4 days, and patient, this child is moderately nourished with bulging fontanelle. So in infants less than 8 months, their fontanelle, anterior fontanelle is open. So we check for the bulging of the anterior fontanelle. That means patient has the meningitis. Patient has temperature is normal, pulse and respiration rate is normal, and then there is evidence of neck rigidity and papilledema on fundus examination. So this is case of meningitis. Now, which type of meningitis is there? TLC is raised. DLC show 80% of polymorphs. So when polymorphs are increased, that means patient has a pyogenic meningitis. Protein are increased and glucose is decreased. What is your diagnosis? It is a pyogenic or bacterial meningitis. And points in favor of your diagnosis: TLC is increased in CSF and mainly the polymorphs. 80% cells are polymorph. Protein is increased and glucose is decreased. So this is a case of pyogenic meningitis. Next case is 10-year-old male child with severe anemia for last 2 years. So long history of anemia, prolonged history of anemia for 2 days, and then patient has attacks of jaundice, intermittent jaundice. Patient is small in stature. Her skin has a bronze color, and patient has the frontal bossing, and the facial maxilla were enlarged. Spleen is enlarged, liver is enlarged, and patient has the history that his brother has similar symptoms and has died. So child WBC count is normal, and blood film show microcytic hypochromic RBCs, red cell fragmented RBCs, nucleated RBCs, and polychromasia. So microcytic hypochromic, RBCs fragmented, nucleated RBCs, and polychromasia, these are the features of hemolytic anemia. Since child it's a child of 10 years, history of his death of his brother because of the similar complaints. So it is case of congenital hemolytic anemia, hereditary hemolytic anemia, possibly thalassemia major. And how will you investigate this case? By doing the HB electrophoresis and HBLC for to confirm the diagnosis of hemolytic, which type of hemolytic anemia, whether it is thalassemia major or other type of hemolytic anemia. Next case is 62-year-old woman complaining of fatigue and numbness of her arms and legs for 1 month. She has the history of hypothyroidism, and she is taking thyroxine. Complete hemogram was done. TLC was normal. Hemoglobin patient has mild anemia. Hematocrit is reduced. MCB is increased. It is 120. Normally is 80 to 100 femtoliter, and it is increased. MCB is increased. Platelet count is normal. Most likely diagnosis is patient has the megaloblastic anemia. It shows that patient has the macrocytic normochromic anemia. So it is a megaloblastic anemia. What is the likely biochemical basis of this anemia? First is there is maybe the decrease in vitamin B12 or folate levels. So deficiency of vitamin B12 and folic acid may be the cause. So this is case of megaloblastic anemia. Deficiency of vitamin B12 and folic acid may be the cause. So 40-year-old male, history of weight loss, loss of appetite, cough, fever, night sweats since 1 month. So it is a long history of 1 month. And patient is moderately built, moderately nourished, and moderately anemic with lymphadenopathy. Patient has temperature is normal and pulse rate and respiratory is increased. X-ray lungs show the consolidation. So this is the history of the patient, and we did the CSF examination. CSF examination, there is increased TLC, DLC. 80% of these WBCs are lymphocytes, and protein is increased, and glucose level are decreased, and ADA level are increased. So this is case of tubercular meningitis. And what is the diagnosis in favor points in favor of your diagnosis? Mainly the DLC show predominating the lymphocytes, and ADA is increased. So this is and patient has the previous history of tuberculosis, pulmonary tuberculosis also. Patient has the history of tuberculosis also, pulmonary tuberculosis also. So this is case of tubercular meningitis. Next case is 35-year-old woman complaining of fatigue and decrease in her energy. And this is the history is for last few months. Normally a very active person. She no longer goes for long walk because she is too tired at the end of the day. Her physical examination reveals pallor. So patient is anemic. Complete hemogram and peripheral blood smear show this HB anemia is there. MCB is reduced. MCHC is reduced. MCH is reduced, and this WBC count is normal, and platelets are increased. So this type of peripheral blood smear is there. If we see these RBCs, they are microcytic, and they have the increased central pallor. So RBCs are small and pale with few pencil cells. So this is typical blood film of microcytic hypochromic anemia, and most likely cause of this anemia in this patient is maybe the iron deficiency anemia. So this is microcytic hypochromic anemia, and cause is the iron deficiency in this patient. Then this is case of 40-year-old male with complaints of increasing weakness, weight loss, and excessive appetite and thirst. So for 2 months, he is suffering frequently from the skin infection and boil. What is your likely diagnosis? So this is the this polydipsia, polyphagia, and polyuria are the cardinal features of diabetes mellitus, cardinal symptoms of the diabetes mellitus. Then these patients may have a history, may have weight loss, and there is maybe the history of recurrent infections. So this is case of most likely diagnosis the diabetes mellitus. What investigations would you do? You will do the fasting blood sugar, postparental blood sugar, and you can also do the HbA1c electrophoresis level of HbA1c. So this is the case of diabetes mellitus, and investigation you will do. Even you can do the urine for